Thanks, James, and thanks, David, for inviting me to one of the best meetings in urology. I've been excited to be here for a long time, and I'm pleased today to be able to share with you some work we've done on cryoablation. I went into practice in 1992, and at that point there was a flurry of interest in cryoablation, and that faded pretty quickly because the results, frankly, were not very good, and there were significant complications, and the science was worse than not very good. And unfortunately, what it did is it colored the word cryoablation or cryotherapy really probably moving forward forever. And so what we have now is the opportunity to look at what's happened since that time. Now, why is the cold registry important? It's because actually, as you know, there's no significant funding in cryoablation. A number of people have completely shut off that it could be a possible modality, and so there aren't going to be large studies like some of those that you've seen in other modalities moving forward. So the cold registry is an opportunity for us to be able to share real-world experience in a number of centers, both private and academic settings. The disclosure on the cold registry is actually an important part of this. It's an online retrospective database sponsored by Endocare or Healthtronics. And importantly, what that means is that we have the ability to look at real-world experience again. We do have funding from outside, which we go over the top to make sure and disclose. But I want to talk to you about how we separated that in a way that we believe brings the science better. The first is by having it run by an independent board of directors. I've had the ability to be the chair of that now for over a decade. Some of the people in the room have been part of that, and it's allowed us to actually be able to go into the data and do some quality work on it to bring the publications that you've seen. It's currently housed by Watermark, which is an independent data center. That was done soon after I took over the cold registry, and the ability to take that completely away from the company having direct access to the data in a way that was able to protect it. And it is the largest data set in existence. When they approached me now over a decade ago, there were several things that I asked for in agreement to run the registry. The first is that I chose to take no compensation for my work on the registry. And as I would always disclose, I do other work with the company over the years that I have been paid for. I want to not by any means pretend that's not been the case. But all funds that have related to work on the registry have been diverted to charity or other purposes, so I've not taken any money in that regard, and that was important to me. Second is that I would be the senior author on all the manuscripts, and that was to assure that as the data came out, that I had the ability to assure that what really came out was something that I felt we could stand behind. The independent board we talked about, and then that we had a 100% decision on whether things got published or not. And the company immediately gave me permission and endorsement to do that, and they followed through on that. So there's been publications that show significant efficacy. I'll share some of with. There have been publications that have shown actually places where cryoablation doesn't work, and by the same token, they've never exerted influence to try to say anything other than we need the data to be out there. So there's a number of limitations to the registry that I think that others can learn from moving forward. It is a situation where the sites enter their own data, so it becomes a heterogeneous data set. It's rare that I go to a meeting that someone doesn't come up and say they want to be part of the cold registry and enroll their data. In the first couple of years I fell for that, and then after that we learned, but what became clear is people often would enter their data even just for the first few months, and then it would fall off for a number of reasons. So we did get away from doing that, and we're trying to now work specifically with centers that have interest in continuing to assure that the data continue. In addition, it's hard to get long-term data. That's due to a number of things, including the fact that investigators retire, they move to other places, they die. We had one investigator who lost a license, and once they're there, the IRB approval says that we have to have a licensed physician, so we, at that point, have to take the data out of the registry, and that'll explain some changes in the registry that I'll show you. In addition, we've got some fields that we feel very confident in. PSAs are obviously easy to do. We're very confident that if there's a fistula, it will show up in the registry. No one's going to miss that diagnosis. But other fields like IEFs and biopsy details, we just have not succeeded in getting to the degree that we'd be able to publish anything meaningful from that. But we have had 16 peer-reviewed publications coming from the registry. The current data are a little bit different than I might have shown at any other point in time, again, because if someone retires or leaves, we can't keep their data in the registry. We just can't continue to analyze those data. So it is the largest data set. We have over 4,000 patients who have primary whole gland ablation, salvage patients almost 1,000, similar to primary focal. We've got a small number of salvage focal patients. That's a little bit lower than what we published recently because, again, some patients had to be pulled out. and then a smattering of repeat biopsies. So now, almost 10 years ago, we published the first group out of this, 1,200 patients that had undergone primary whole gland ablation, a pretty typical population, but importantly, only 136 of those had at least a 5-year follow-up. So we found a number of things. One is that only about a fourth of the patients actually underwent biopsy. Of those who underwent biopsy for cause, in other words, had a rising PSA as we would have taken in any other setting, the positive biopsy rate was almost 40%. So, and then if they had no cause, if it was done per protocol, it was a positive biopsy rate of about 15%. And if you think in the acute setting, although it's been quoted here earlier today that only 25% of biopsies are positive, about 40 to 50% of all initial biopsies are positive in almost every study that's come forth in the past decade or more. And so what you see here is if you're suspicious of cancer and you do a biopsy, you have about a 40% chance of having cancer. And if you're not suspicious of cancer, so if we went through everybody in the room here who had hair as gray as mine and did biopsies, we would find about 15% of those men have cancer. So it's really not any different than in that setting. Urinary retention rates were low. Rectal fistula rate, which is the area that originally ran cryoablation out 20 plus years ago, 0.4%. Incontinence about 5% and 3% in pads. And most patients who were sexually active did not return to intercourse. And frankly, most patients who are sexually active don't end up getting cryoablation in most of the practices. Now, as far as determining whether that was a successful procedure, there is no standard yet as far as determining was cryoablation successful, other than if we did prostatectomies afterwards, of course. So you could look at Astro or Phoenix. You could look at undetectable PSA, which one of the reviewers in the journal Urology required us to put in there, and it's a meaningless study considering we know that we preserve tissue in cryoablation. And then Nadir PSA. So as opposed to choosing one of those, we actually have pretty consistently reported both Astro and Phoenix with all of our outcomes. And basically you see Kaplan-Meier curves that are not indifferent from other forms of accepted therapy. We also, though, came back later with a group of patients, over 1,000 patients had a minimum 5-year follow-up. So some 5-year papers you see, the first patient had 5 years and everybody else had less than 5. All of these patients had a minimum 5-year follow-up. And we saw, again, Kaplan-Meier curves that are comparable to other forms of treatment based on low, intermediate, and high-risk cancer. What we found otherwise, though, is that the Nadir post-cryoablation, which was typically the 6-week read, which we know now may not be the true Nadir, and we're working on some research on that. But we see that if the patients reach a Nadir of less than 0.4, they have very good biochemical outcomes regardless of regardless of risk structure. And if the Nadir doesn't reach below less than 0.4 in that primary setting, in all likelihood, we failed to cure the cancer. We've subsequently been able to look at a number of other scenarios, including bulky disease, high-risk patients in the elderly category, many of which are now being diagnosed and have the opportunity, as you know, for surveillance. We have the salvage setting and the focal setting, and I'll go through those. So with patients with high-grade cancer, one of the original hypotheses was that you shouldn't use cryoablation because maybe it wouldn't be as good. And what we see is actually high-grade cancer will die like low-grade cancer, but there are some caveats to that. And so even in those patients with high-grade cancer, if their PSA is higher, actually we do see separation in cure rates regarding the lower PSA. More importantly, in my opinion, is that if they have pure pattern 4, so if you have Gleason 8 cancers, we see that they actually do less well than patients, than patients who have any pattern 5 cancer. So there is probably some sensitivity issue there. But in that setting, we again get affirmation that the post-treatment Nadir is the determinant of whether they're likely to have long-term good outcome. We've also published in patients who've had whole gland primary treatment in the elderly, and actually a number of patients have been treated, as you see in the numbers there, in that greater than 75-year-old population who have mostly high-risk disease. And I'm often have the question of, should you treat a patient who's 76 years old, and if his father's there and he has in great health? Many, as you know, and I recently saw a patient who had been treated with active surveillance with Gleason 9 disease because he was 85 years old. Well, he had widespread metastatic disease at 91, and he was perfectly healthy other than having incurable metastatic disease at that point. So we have to rethink that. In the salvage setting, our original studies, again, now almost a decade ago, were in 280 patients, so obviously fewer patients, and the same thing, 5-year follow-up only in about 50 of those patients. In that setting, we chose not to separate by high, low, and intermediate risk, and this has been an ongoing debate among some of the board, is that I would regard anybody who has post-radiation recurrence as being high grade. Others would say we can seg them, and we've started doing both. But again, what you see there is that we would expect that, depending on definition, 50 to 60% chance that 5 years post-treatment that we would still have biochemical success in the post-radiation setting. In that setting, we know the complications are a little bit higher. Fistula rate, 1.2% in that group. Retention rate, about twice as high, about 3% required TURPs. And the incontinence rate, which seems low to me considering our recent data, but at least in that setting, the incontinence rate was actually only about 5 or 6%. When we do stratify them, though, what we see now in unpublished but subsequent data is that you do see some differences if you take the post-radiation setting and segment by high, low, and intermediate risk based on traditional definitions. You do see some separation of the curves, and there in the high-risk patient, less than 5% of those patients 5 years post-treatment will be biochemically free. In the salvage whole gland setting, we also looked at patients who've had neoadjuvant treatment. And the important thing we find here is that although the hypothesis is in that setting that giving neoadjuvant treatment before cryoablation is done, some of the investigators clearly felt that that would be beneficial. That turns out to be absolutely the opposite, and the patients who had neoadjuvant treatment actually did worse, not better. My hypothesis on that would be that those patients may have had worse disease, but very clearly neoadjuvant treatment is not a panacea in the post-radiation cryoablation setting. And then in that same setting, we see continued the same separation on if the patients get a low nadir, less than 0.6, and actually subsequently our data would support less than 0.4, we know that's the patient who's likely to not have local disease or biochemical recurrence, and biopsy is probably not necessary in follow-up, barring some significant changes in PSA. Here, again, we've done the same thing and shown that that'll go across risk groups, that in that salvage setting that the nadir maintains across all risk groups. The final population is the focal treatment setting, and we've basically developed a series of nomenclature, or a definition of nomenclature. We have this in the registry such that when patients undergo focal ablation, the investigators can put which type of focal ablation they have. And what I can tell you is almost all of those are actually hemiablations in the series we've reported. John Ward and I several years ago published that the growth on this was obviously substantial, that focal therapy was taking off. Importantly, in that group, we found that focal therapy was not being done just on those patients who shouldn't be treated, which are the low-risk patients, but the majority of patients were intermediate and high-risk disease that were getting focal therapy at that point and subsequently as well. And what we see in that focal setting is compared to whole gland at the bottom, the bottom line is that we tend to see biochemical outcomes, or Kaplan-Meier curves of biochemical outcomes, actually being similar in the focal group to the whole gland group, meaning that most patients who are undergoing focal therapy appear to be doing that based on the right choices, the right patients are getting focal therapy. The other issue with focal therapy, of course, though, is why do we do it is if we're doing organ sparing, it's theoretically to protect some outcome. And so we do see in bold there, compared to whole gland or salvage treatment, we see that the patients actually are going to be less likely to have incontinence, about half as likely. They're going to be less likely to have fistula. Only one patient in the entire 1,000 patients had a fistula. And urinary retention, less than 2%. So all of those are favorable. What's not clearly favorable is protection of erectile dysfunction. So in those patients who underwent, again, mostly hemiablation, the bottom line is that still about 40% of those patients had erectile dysfunction afterwards. And so at least hemiablation clearly, again, is not a panacea for preserving erectile function. Other issues we looked at in the salvage setting is that we developed the concept of a bifecta. So we've talked about the trifecta with radical prostatectomy. In the patient who's been radiated previously and undergoing cryoablation, whole gland cryoablation in this report here, we would not expect them to be sexually active. As we know, many of them might not be sexually active because of their age, because of the prior radiation, but that we felt that was not even something that was trying to be accomplished in the whole gland salvage setting. But we did expect them to be continent, and we did expect them to have be biochemical disease-free survival. And we found that about 70 to 75% of those were able to accomplish those two goals. One of the other findings that we published is that salvage patients have poor outcomes if they have seminal vesicle involvement. That's actually in both my own experience, but I suspect that it's why we've also published that in the T3 setting, extraprostatic disease, that cryoablation does not tend to do as well as other modalities. So in the patient with extensive extraprostatic disease, our publications would suggest that's not the patient to treat with cryoablation. Then the last frontier would be the patient who can undergo focal, salvage, or partial gland treatment is, again, theoretically, we could reduce the morbidity while still curing the cancer in appropriately chosen patients. And on a biochemical disease-free survival, we show that that turns out to be the case, that we actually have as high likelihood to have disease control as we would with the whole gland setting or whole gland treatment. What we weren't able to accomplish, though, was to have an adequate reduction in post-cryoablation complications. So again, post-radiated patients who undergo focal ablation, and that we actually had as high risk, if not higher, of fistula. There were 3 patients out of slightly over 100 that had fistulas in that setting. Urinary retention was certainly not lower, and the 12-month incontinence was not lower as well. So my initial enthusiasm for focal salvage cryoablation has waned some. I believe we can do this better, but at least in the first 100 cases, not uncommon for the first 100 cases of anything, it did not turn out to provide the benefit we would have hoped in the short term, and then again segmenting it by risk category. So the key takeaways from that would be that the Cold Registry is the largest source of cryoablation data, and that it's the best data we've got to be able to evaluate the role of cryo in any of these settings. Primary and salvage therapy can be accomplished with either whole gland or focal therapy if the right treatment is given to the right patient, and I think that's the real key here with any form of ablation. And then finally, as we know, there are an increasing number of men who have previously had radiation, and that we believe that that's a highly likely to be a growth area in our practices for focal ablation. I appreciate it very much.